Hello and welcome to the Biohackher Podcast. I'm Azra Alagich, your host and founder of Biohackher. I'm an integrative nutrition health coach specializing in longevity for women, a health and wellness journalist, writer, corporate consultant, and a biohacking advocate. Biohackher is a space where we can explore ways to optimize our health to live well longer. Whether it's through improving our nutrition, exercising, cryotherapy, supplementation, technology, and more, I'll be bringing you information and interviews with the best longevity experts to help you understand what you can do to optimize your health, prevent disease, and slow down or even reverse the symptoms of aging by taking control of your unique bio-individuality. Want to know more? Let's dive in. Hey everyone, welcome back to the Biohacker Podcast. As some of you might know, I'm not only a podcast host, but also an integrative nutritional health coach. As part of my mission to help women live well longer, I'm excited to share that I have launched my first Biohacker product, my Good Gut Granola. I created this recipe after navigating my own gut health issues and struggled to find healthy breakfast options that didn't taste like cardboard. My cranberry and walnut granola is gluten-free and vegan, and each ingredient has been specifically chosen because of its science-backed ability to support longevity. And I haven't compromised on taste to achieve a healthy granola. But I apologize in advance because once you start eating, you will become addicted. It's that Moorish. It's now available for my Australian listeners, and you can purchase it online from www.biohack-her.com, where you can also download a free copy of my ebook, Biohacker Live Well Longer, a beginner's guide to biohacking for women to optimize your health. Hi guys, today I'm thrilled to be joined by Dr. Ceri Cashell, a women's health and hormone specialist who has dedicated her career to helping women navigate the often confusing and sometimes overwhelming transitions of perimenopause and menopause. Dr. Cashell is passionate about bridging the gap between what women are told in the doctor's office and what's actually happening in their bodies. She brings a wealth of knowledge on hormones, longevity, and functional medicine, and she's not afraid to challenge outdated thinking when it comes to women's health. In our conversation, we'll be diving into what really happens to our hormones in midlife and why it matters, the latest science on how women can manage perimenopause and menopause with more ease, and the practical biohacker-approved strategies you can start using today to feel vibrant, strong, and unstoppable no matter your age. So whether you're in the thick of hot flushes, just starting to notice the shifts of perimenopause, or simply curious about how to optimize your hormones for longevity, this episode is packed with insights you won't want to miss. Let's get into it. Here's my conversation with Dr. Ceri Cashell. Dr. Ceri, welcome to the Biohacker Podcast.
Thank you for having me, Azra.
Great to have you here. There's been a lot of mixed information out there about perimenopause and menopause, and I think a lot of women have been getting frustrated about those mixed messages. What's your take on this and the amount of care that's out there or the lack thereof for women going through this major transition?
Yeah, I think it is extremely difficult for women today to try and separate fact from fiction. And I think it's also difficult for doctors as well. And there are so many different sources of information. We live in a world of information and misinformation that it can be really overwhelming, especially for people who are probably already a bit biologically overwhelmed by the stage of life that they're in. But if we look back to the last millennium, the last century, in the 1980s and 1990s, menopause and perimenopause was reasonably well supported, and there was a real acceptance that it was reasonable to use hormones and it was safe and it reduced your risk of heart disease and it was effective for the treatment of menopausal symptoms and reduced the risk of osteoporosis. And certainly a significant number of women were able to access hormones if they wanted to. And then we had this study that started in the late 90s and ran to 2002, which really, I think for want of a better word, devastated that care, because this study, for whatever reason, came out with a headline that hormones cause breast cancer, and overnight women stopped using hormone therapy as part of the treatment of menopause. And really for the last 20 years, doctors, researchers, clinicians, and women and people have been terrified of hormones, and breast cancer in a lot of countries is women's number one fear. And as a result of that, I think medical research, medical education, medical training and practice has really meant that we've been trying to manage a hormonal change without actually using hormones, which when you say that sounds slightly crazy. And we're really trying to undo the damage of a study that was at best misreported. So when you actually go back and read that study and look at the raw data, that headline that came out that hormones caused breast cancer wasn't even true at the time. And, so that has really done untold damage. And if you go into the data and you look at it, you'll see that hormones used at the right time can be very protective for a woman's future health, as well as what they were never trying to do, which was that it is one of the most effective treatments for menopausal symptoms. So that one study has really created so much misinformation that the data from that study is used in a lot of papers that have been published since. It's also used in online calculators. It's there as part of guidelines. It's there in patient information leaflets that come with hormone products. So from every angle, if a woman actually decides to use hormones and can manage to get them from her doctor, she still has to get through these layers of fear, manifesting itself in guidelines and patient information. So I think that's probably one of the biggest things that has created this fear, and fear drives misinformation. So we're really trying to undo that and to go back to the basics and reassure women that hormone therapy is a safe part of your management for menopause. And then if we can move out from that, we can do so much more with all of the other modalities that absolutely play a role in supporting women in this phase of their life.
Do you think that there's also misinformation still amongst the medical practitioners that treat women for perimenopause and menopause as well? Do you think that that's part of the problem, that this misinformation has been so embedded within our culture, within the medical fraternity that help women going through perimenopause and menopause, that there still needs to be a lot of work done to be able to undo that misinformation?
Absolutely. I think that doctors and clinicians and prescribers are human too. And the way our brain is wired is that bad news sticks. And it also sells, we're wired for danger. So it's very difficult to undo an emotional association of fear by looking at facts. So, even if I present, the facts to my patients or even to colleagues, they often are still concerned because they can't get past that fear association. And that is, how the human brain is wired, whether you're a clinician or not a clinician. So absolutely, I think we've got a shift where women are actually understanding this more, but and there's a real friction point where more women want to try hormones than doctors want to prescribe them. And I think as doctors, we're trained to first do no harm. So it's not coming from a place of, of being mean. It's that we really don't want to prescribe something that's going to increase a woman's risk of breast cancer, which hormones do not. There is no evidence that natural hormones ever did, and there is no evidence that they do now. So, but for doctors to move out of that fear where it's just drummed in, it's been drummed into anybody that's been practicing in the last 20 years that estrogen causes breast cancer. And it was never shown. It was a synthetic progestin that was associated. So it was never even estrogen. And it somehow got vilified, which, is probably some kind of, misogynist turn, of female control. But, estrogen was never associated with breast cancer, even in that study back in 2002. So absolutely, clinicians have really struggled to pivot and to change their mindset about the safety of hormone therapy.
And you can understand why women would react to that misinformation, because when somebody hears the C word, that this could potentially impact you in that way. And we identify so much by our feminine bodies as well. For a woman to lose her breasts, I mean, that's very difficult, obviously. That doesn't make the whole woman by any means, but it's certainly, a challenge to have to go through something like that. So you can understand why women
Absolutely
react in that way, right?
Yeah. I mean, breast cancer is, when they've studied, and certainly in Western countries, breast cancer would be there as women's number one fear in terms of their health concerns. They're not scared of osteoporosis or dementia or heart disease. They're scared about breast cancer. And it's really important that we look at breast cancer as a separate entity to menopause, because it is really important. And, it is still the most common cause of cancer in women. So we need to look at be doing good screening and, putting in practices, health lifestyle behaviors that really reduce breast cancer, but considering it separate to menopause. Unfortunately, breast cancer increases in perimenopause. It increases as you get older. The biggest risk factors for breast cancer are getting older and being a woman, which sounds stupid, but it's really important to say that, because it is women getting older that take hormone therapy. So you will have women, everybody will know somebody that took hormones and got breast cancer. So, and we're always looking again as humans to have a reason why did this happen to me? Why did this happen to my mum, my sister, my friend? And it's very hard to accept that there's probably multiple reasons why these things happen, and that the hormone therapy, there's no evidence to suggest that it has a role. Breast cancer develops, we think, probably on average between 7 to 10 years. So when you present with a lump, the cancer's been developing for a long time. And this idea that, you started, hormone therapy last year and you got breast cancer this year, that there was the hormone therapy that caused it, doesn't hold any sort of sway even in basic science. But it's trying to logic. And this is the problem with fear. It's very emotional. So it's very hard to sort of untangle that with facts.
For sure. And everybody experiences fear in very different ways, right? So in terms of the hormones that are available for women, is HRT, is it apples with apples? What should women be looking out for? Because you've got synthetic hormones, you've got bioidentical hormones. What are the best hormones that women should be looking for?
So it's always a very individual, case by case. What's right for you is not going to be right for your friend or your sister or your mum. But what we like to use when we're using hormone therapy, or as we like to call it, precision endocrine therapy, or progesterone, estrogen and testosterone, really calling it what it is using body identical, which is the same as bioidentical. Body identical is just TGA approved in Australia, and those terms are used interchangeably in the States. So body identical are TGA approved body identical hormones, which means the chemical structure is identical to the hormones that your ovaries and other parts of your body produce, except it's made in a factory and it's made from yams or soy. So it's plant-based medicine that has gone through a factory process. But it should really, when it attaches to your hormone receptors in your body, it should give an identical effect as your own hormones would have done. So those would be the gold standard. And when we use estrogen, or correctly estradiol, we like to use it through the skin as a gel or a patch. And that works for the majority of women, although not all. About 20% of women struggle to absorb through the skin. And the reason we like that preparation is because it avoids going through the liver, which can cause an increased risk of clot, like a DVT or a clot in the lungs. So estrogen through the skin is extremely safe. There's really not any significant contraindication in terms of migraine or high blood pressure, or previous heart disease or previous stroke. All of those things don't apply to transdermal through the skin estrogen. And then we use progesterone. It has to come as a capsule. You don't absorb enough progesterone if you use it through the skin. And progesterone typically has been regarded as just protecting the lining of the womb. but we now appreciate that it's a neurosteroid. So it's very active in the brain, not just in the uterus. So even women who've had a hysterectomy or might have a Mirena, an IUD, hormonal IUD, find progesterone is great for anxiety and insomnia. Some people even find it helpful for low libido. And then the third hormone, which isn't really a menopause hormone so much, is testosterone. Our testosterone peaks in our late 20s and then gradually falls across the decades like it does in men. But probably for some women, it really falls quite precipitously at some point, and we don't really know why. Testosterone, again, is given as a cream. Australia is the only country to have a licensed product for postmenopausal women, but perimenopausal women do often use it. And again, got great safety data. So those three body identical hormones really have good safety data for up to about 10 years for the progesterone, 20 years for testosterone and estrogen. And so that's what we should be aiming to use for women. And the estrogen, progesterone are on the PBS, so they're affordable. Synthetic hormones we tend to use for contraception. So we've got contraceptive pills, which might be progestin, which is a synthetic progestogen, so different to progesterone. And we've got the Mirena IUD, which has got a synthetic progestin in it, great for heavy periods and using it as a contraceptive. And then estrogen, usually in most pills, would be synthetic. There's two that have got natural estrogens in them. And they have a role, if you're needing to try and flatten out the fluctuating hormones, or if you need contraception or you're managing heavy periods. So they all have a role. But unfortunately, we don't have a fully natural contraceptive pill. Women have just been expected to suck up side effects. I'm pretty sure if it had been, the other half of the population, we would have had a body identical contraceptive by this point of, 60 years from when the first contraceptive pill was marketed.
For sure. And hopefully, somebody out there will start to be looking at that, and we'll start to see some improvements in these hormones moving forward. You mentioned before about how as women get older that there's a higher chance of getting breast cancer. Do we understand why that is? What is it about the aging female body that increases the likelihood of breast cancer?
So it's the same really for any cancer or chronic disease, that the regulation at a cellular level becomes disorganized. It's like your batteries are starting to struggle. So you're not as good at recognizing faulty processes. So you might leave cells that are misbehaving, and that does that risk accumulates, year on year. So these are cancer and heart disease and osteoporosis and dementia and arthritis. These are all diseases of inflammaging. So inflammation that increases with age. And that really drives all cancers, and that's why we do start to see these things increasing as we get older. And breast tissue has a lot of turnover through life, it is very hormone responsive. So breasts do change throughout the menstrual cycle. They change in adolescence. They change again in perimenopause. So any tissue where there's a lot of change and turnover, it means there's an opportunity for things to go awry. So any time where they're like skin, that's why we get so many skin cancers, because the skin is turning over at such a great rate. There's a chance for one of those turnovers to go down the wrong pathway and become a cancer. And so that's why breast would be sensitive. But particularly it's an area where changing hormones in life probably have made cells a bit more sensitive.
Mm. As part of what you do in trying to lift the lid on what's available out there for women who are going through perimenopause, menopause, you were one of the powerhouses behind organising the event So Hot Right Now. What was your driver for that?
Oh, I just thought the time was right for putting menopause on a big stage. And I think there's a danger, when you are hitting midlife yourself, that you do come into your own power and you have these crazy ideas. And if you're surrounded by other women who are, a bit energetic and empowered, you do think, gosh, I can do this. And women as a collective are extremely powerful. And I've got some wonderful friends, some of whom you know well. And, really you can, we are a bit unstoppable when we decide something can be done. And I was very fortunate, to be in a group with Dr. Louise Newson and Mary Claire Haver and Kelly Casperson and Vonda Wright, through sort of my menopause activism and advocacy. And, I've become quite a good friends with Louise, and I knew that they were mad keen to come, and they were delighted to come to Australia and speak to Australian women. Australia is a great place for opportunity. There's other countries where it's hard to sort of do things, but I think everybody's very connected in Australia, and you can sort of reach out and make crazy things happen, like putting menopause on the stage at the Opera House. And it was amazing, so I'm still probably recovering from it. But to have all those women in that room and that palpable joy and community, like that's when women come together, it is absolutely a beautiful, beautiful force.
Isn't it? And I can see the joy on your face from that experience, and it must have been absolutely buzzing. Unfortunately, I wasn't able to make the event, but I'll certainly be there at the next one if you're ever planning to do another one. But it's you're right. Women, when we come together, we are absolutely unstoppable. And I love the fact that there were so many women that supported you in this cause, because who would have thought that we would be talking about perimenopause, menopause in the Sydney Opera House? I mean, this is an international landmark, and it's always been such a taboo subject for so many years, really. And that's so frustrating in my mind to think that it is such a taboo subject. I mean, like, oh my goodness, we can't talk about the fact that a woman is stopping, menstruating, and what's such a big deal about that? Why is that such a taboo subject? And yet, you talked about it in the Sydney Opera House, which is so iconic. So I love it. I think
yes, we have to stop valuing women solely on their fertility. We are so much more than breasts and uteruses. Like we're brains, we're hearts, we're bones, and that really sort of transects like health and society and economy. In health, women's health is really all about the uterus and the ovaries and breasts. But actually, when we look at health, our brains are different, our hearts are different, our bones are different. So in health, we need to have a very different model for managing female health and disease prevention and treatment of disease, which we still don't have. And in society, we expect women to comply to models that are very much set around, again, what suits men. And that is, again, disservices women. And I think it's really, and we also really don't allow women to age. And with age comes wisdom, and we become these superpowers, but we do need support in different ways to really, come into that amazing power in our second half. So there are changes that I think that we can make that would make a huge difference, like in every aspect of society, that would actually improve the whole of society rather than sidelining us and making us invisible at 60 or 55 or whatever.
For sure. And I think you make a really important point there about that we are not allowing women to age. And you just have to take a look at what happens to women who are in front of the camera, actresses, TV anchors, whatever position it might be. There's this pressure on women to constantly look young. And so while I'm a biohacker, I do feel that women should be given permission to age, but to age well, and to be able to look at how we can continue to do the things that we love to do. But there is this ridiculous amount of pressure for us to stay young and to not have wrinkles and to not have grey hair. And just because you have wrinkles and because you have grey hair, that doesn't mean that you're not thriving and that you're not vital and that you still can't be an amazing powerhouse like you are, and like the women that were on the stage, at the Sydney Opera House as well.
Yeah, I think as doctors, we're very lucky in a way that we don't get sidelined as well. That certainly has never been my experience, that older female physicians or doctors we are allowed to age. So we're very lucky. And I think that seeing those women who are really still accelerating in their professions, again, sends out this powerful message. I mean, these are women and doctors that I really look up to, or who are a bit older than me, but only slightly, but showing that this is wisdom and experience, and we should have that same respect in all professions. And it very much doesn't exist in so many professions, especially, as you say, where women are camera facing, or in advertising. There's a lot of professions where women are just pushed out and no longer considered, cool enough, which is just crazy. It's such a loss of wisdom in so many professions.
Yeah, definitely. With perimenopause and menopause, there are so many symptoms. I think there's a couple of hundred symptoms, correct me if I'm wrong. What are the most reliable signs that a woman can look out for if she's going through through perimenopause? Because how did you differentiate between those symptoms as opposed to it just being stress from daily life or it actually being a perimenopausal symptom?
Yeah, so it's almost impossible, to be honest, is the short answer. The long answer is that once you understand that every single cell in the human body has estrogen receptors, probably progesterone and testosterone receptors too, we just haven't looked, then you can appreciate that when estrogen falls, progesterone, testosterone too, then every cell can be affected and any system can be affected. And that's why the range of symptoms of perimenopause continues to grow. So traditionally, we very much thought about the symptoms that are called vasomotor, which are hot flushes or flashes and night sweats. Sometimes people get cold, and that's to do with falling estrogen in the brain affecting your temperature sensing system. So that would always have been the main symptom as regarded to being the classic perimenopause and menopause symptom. And about 70% of women will get those. And that's the symptom that all the new drugs target. But I think I've had one patient where that was the symptom that really bothered them. The things that women struggle with are mood changes, and it's difficult because a lot of these women have a history of mood disorders. So how do you know this is perimenopausal mood, or is it just an exacerbation of a previous mood, or is it related to stress? And the reality is you can't. You have to kind of lean in and look at somebody's age, and really a lot of the time we're doing a trial of treatment. So the anxiety, the insomnia, the irritability and rage are unusual symptoms of a primary mood disorder or stress. That kind of, I'm going to kill somebody one day and fine the next, is a good marker of hormones. And then there's other ones like palpitations, very common symptom in perimenopause and menopause, fatigue, unexplained fatigue. And again, there's other things that can be happening in this time of perimenopause that contribute to fatigue, such as, stress and falling vitamin D or sleep apnea. And then the gut changes. Vaginal dryness is another one that can only really be caused by loss of hormones, although that can happen at other stages in a woman's life, like after having a baby or being on the contraceptive pill. And then joint pain and tingly feet, burning mouth, tinnitus, itchy ears, really it can be anything. So we're always sort of as clinicians going, well, we should be going, does this look like perimenopause? Does it smell like perimenopause? Probably is. Do some bloods, checking at the same time, ruling out other conditions, but at the same time, if the woman wants to, doing a trial of treatment. And it can be amazing, like how many of those symptoms will disappear within a few weeks. And then you're left maybe with something else, or you might be left with somebody who's just back to themselves. So it does vary. So it's a bit of art meets science, really. And checking it's not anything serious is always, as a doctor, that's what we're always trying to rule out, the nasty things that might be hiding behind what we might think is perimenopause.
Yeah. I feel like perimenopause hasn't had as much attention as what menopause has. In your mind, what does best practice perimenopause treatment look like moving forward?
So I think we always start with the basics, but it's always tailored to the individual. If you've got somebody coming in who's barely holding on to life by the threads, I'm not going to sit and lecture them on their nutrition and lifting heavier weights. So, it really is tailored to the person in front of you. And sometimes it is trying to scrape them off the floor and get them onto the seat, just to be able to do things. But if we look at it in the kind of lifestyle first, that's optimizing your nutrition. So your cravings can go up in perimenopause as a result of hormonal changes and fatigue. So really getting back to eating plenty of protein, plenty of fiber, always real food. It's not rocket science. Eat when the sun's up, sleep when the sun's down, really trying to pay attention to your 24-hour clock. You just can't cheat sleep. No, you can't just sleep at the weekends. No, you can't just sleep when you're dead. You're going to die sooner if you try. Breathing through your nose, really underused modality is just breathing exercises. So get a breathing app on your phone, do it 4 times a day for a couple of minutes. It's going to do you so much good. There's evidence it reduces dementia and it's good for your heart, probably even good for your bones. Trying to do exercise, but do something you like. I don't tell people to go to the gym if they've never gone to the gym before. They're certainly not going to do that when they're struggling in perimenopause. I only exercise at home or go for a run. So just doing something, and preferably something you enjoy. I think really important to sort of get rid of the people that you don't like. I don't mean, like get rid of them in a kind of sinister way, but, really put in some boundaries and you make sure you're maintaining your social connections with people that make you feel good about yourself. But it's a great time to create some boundaries, and it can be helpful for people to get some psychological support. Trauma will often reappear or appear for the first time when hormones fall in your brain, and there is a biochemical reason for that. But often women start to struggle maybe with things that they haven't really thought about for a long time, so it can be quite an emotionally and psychologically challenging time. So a lot of my patients do see a psychologist for some support. And then you've got any range of supplements, but really for a lot of women it is hormones that makes a big difference. So, and, just finding the right mix that's right for that person. Some women are very sensitive to small doses of hormones, especially people who are maybe neurodivergent or who have a history of sensitivity to the pill. Another area I'm very interested in is women who do have sort of overactive immune systems. They can be a bit sensitive to hormones as well. So sometimes we need to work on calming down the nervous and immune system first before we go in with hormones. So that's something I've learned more recently. So that might need an even more tailored approach. So it's really that lifestyle, hormones, psychological therapy, seeing a physiotherapist, that kind of in terms of treatment. And it's an important time to get all your screening checked. I get all my patients to do a bone density if they can afford it. It's, about 40 to 50% of women by 50 have lost significant bone density in my experience. And you want to know about that so you can crack the whip and get yourself lifting, and making sure your breast screening's up to date, your cervical screening, your bowel screening. Australia's got one of the highest rates of early bowel cancer in the world, and the majority of those cases are in women. So 51% of women of the early bowel cancers are actually women. So really important that we address all of those factors, in this phase, as well as thinking about what we need to do going forward.
I think for perimenopause as well, it does start quite young, in your mid-30s. I've got a 35-year-old daughter and she hasn't had children yet. And in the back of my mind, I've got this little voice saying, well, should I talk to her about this? Because, she starts showing signs of perimenopause and she hasn't even given me a grandchild yet. No pressure. But, it is a consideration, right? I know. It is a consideration. So what would you say to women at that age that might be staring down the face of perimenopause symptoms already? Because I remember when I was 35 and I would not have even thought that I would be looking at anything close to menopause at that age. You don't think about that as a 35-year-old, right?
Absolutely. And you're right, because the average age of menopause is 45 to 55, and perimenopause can start 10 years before. So that would take you back to 35. And, and some women do go into menopause as young as their teens. So that's, under the age of 40, if you're actually menopausal, so your periods have stopped, that's primary ovarian insufficiency. And it's not that uncommon. So POI, menopause under 40, affects maybe 5% of women. Although, even if you do get that diagnosis, some of those women will still manage to conceive. But I think there's so much in our environment that really stresses our hormone axis out. We don't have great data looking back at when perimenopause would have started, because as you said, perimenopause has only really recently become part of our lexicon. Certainly I got no teaching about perimenopause, just menopause, and that was barely mentioned. So I do wonder, with our environment of, our screen time, LED lights, sedentary living, plastics, all the other things, we know that is affecting our hormonal axis. So I think as a woman, whatever age, is always trying to just looking after your health, of which your hormonal health is part. And that is your basics again, your food, your nutrition, your exercise, your sleep, your stress levels, because it is, certainly some people do find by really modifying those extrinsic environmental stressors that their hormone axis will reboot a little bit. Not for everybody. Some people, it's so biological, those things are not going to help. But for some women, I do think if you really, do as much as you can, really look after those aspects, you probably can maybe buy yourself a bit more time. But equally, these are natural hormones. We have no problem throwing people from the age of 12 onto the combined contraceptive pill, which is synthetic. Yeah. So we need to be less scared of these natural hormones, which are safer. We're just giving you back what your body's used to. So they can have a role at any age, and they don't stop you getting pregnant. And there's some people would say may even support pregnancy because you're not as stressed because you're sleeping with your bit of progesterone, or you've got more energy with your bit of testosterone, so certainly I think there's no age that it's too young for somebody to try hormones, but always looking at those other modalities as well, which are extremely important. Hormones are not going to work on their own.
That's interesting. So you don't think that there's any young age that we should be scared of giving women hormones?
Not natural hormones, no. I mean, I think they've been used like natural progesterone since about the 1950s for girls who had severe PMT to really support them in that, week or two before their period when their progesterone was really high and then falls off a cliff. So, the majority of women do get PMS, up to 90%, premenstrual syndrome, and then a percentage of those women, so maybe somewhere around about 8% of women get severe PMS or premenstrual dysphoric disorder. And that can, in some women, respond to natural progesterone, which really trying to stop that plummet. So it's not that there's anything wrong with your hormones, it's just your receptors are very sensitive. So using natural progesterone there can work for some women. Other people, the synthetic pill is better because it flattens your cycle, and that's reasonable. It's really just working out what's right for each person. But, we really have demonized natural hormones. When you look at it, how easily we prescribe synthetic hormones, which absolutely have a role. I've nothing against the pill at all, but we seem to be irrationally scared of something that our bodies produce naturally, which doesn't make logical sense to me at all.
Well, I suppose because people think that if it's coming out of a box and you're getting it from the chemist, that it can't be natural. Right?
Yes. But they don't worry about the pill, so if you put your little HRT pills beside your contraceptive pills, people are not scared of on the whole, people are not scared of contraception, but those are much higher dose hormones and they're not natural. So it's a real, disconnect.
It's a mindset thing, I think, as well, isn't it? Because I think, okay, if I'm taking the pill, there's a pretty strong reason why I'm taking that pill. It's because I don't want to fall pregnant. Not that women haven't fallen pregnant on the pill, and I'm a classic example of that, twice, mind you. Being on the Metapill, and I fell pregnant both times. But then taking natural hormones, you're like, oh, okay, there's some risks, perceived risks, that as we've already discussed about the miscommunication out there. And I'll just suffer through it. I'll suffer through the hot flashes.
Yeah.
It'll pass soon, right?
Yeah, no,
that's a mindset for some women.
Yeah, we are our own worst enemy in terms of our stoicism, and I think things like hot flushes or flashes, there's talk you can use cognitive behavioral therapy and hypnotherapy to try and manage them. But what's really important about hot flushes or flashes is that the more you have, the more likely you are to have heart disease. Your brain does not like those episodes of temperature dysregulation. It's associated with an increased change in what's called white matter changes in your brain. So, there's changes happening. It's like, these are not benign symptoms that we should suffer through. They are the canaries in the coal mine. And, it is sensible to think about reducing them. We don't say just see how you go with your chest pain or your breathlessness. No. So there is, and, it's the same thing with heavy menstrual bleeding. The majority of women don't go to the doctor. So I think about 70% of women with heavy menstrual bleeding just put up with it, live in a state of chronic iron deficiency. And all of these things stress your cells. Your cells don't like fluctuating hormones that are all over the place. They don't like lower estrogen because the mitochondria, our little battery packs, need estrogen to function. So we don't like running on like low fuel or rapidly fluctuating roller coaster type hormones. So it's really recognizing at a biological basis and taking it, this is not something that you're going to get a badge for putting up with. Not a good badge.
Yeah, and you age faster too. If you're allowing yourself to suffer through that, and you're getting high cortisol levels as a result of that, and you've got low grade chronic stress for an extended period of time. Well, what does that do to the body? As you said, it inflames the body and accelerates the aging process. So don't suffer, ladies. Go see the doc.
And it is really even people who don't get symptoms off, say I had no symptoms. And I got through menopause. And it's really important to understand that menopause is just one day, 12 months after your last menstrual period. And then you're postmenopausal for the rest of your life. So those hormones are not coming back online. There's no amount of protein or weight training that's going to bring your estrogen and progesterone back. They have left the building unless you replace them. And what we see in menopause transition is we see that cardiovascular disease, the risk of having a heart attack, doubles over that time. You lose your bone at the fastest rate in the 5 years around menopause. It starts about 3 years before the last period, and you lose up to 25% of your bone density. Your risk of diabetes doubles. The risk of insulin resistance doubles. We know we can't look at dementia because it's a much more long-term chronic disease. But these are big diseases. Heart disease is still, it sort of competes with dementia in Australia as being the number one killer of women. But we ignore this opportunity to really reduce risk. And there's excellent data that estrogen, when it started in that 10 years after menopause, reduces the risk of a heart attack by up to half, which no other drug does. So exercise and everything's really important, but there's no other drug that will half the risk of half the risk of having a heart attack for a woman. And, and that was one of the figures that they buried in that study, which is, criminally negligent really in my mind. But, women should understand that these are very safe. There's never been an increased risk of breast cancer seen with estrogen. It possibly reduces your risk of heart attack by half. And it will treat your hot flushes, your irritability, and your general, wanting to kill somebody, which is good for everybody around
That's
you.
That's always a good thing, right? Yeah. Walk us through timeframes. Is there any time at all that a woman should stop being on HRT? And if so, what ages should that be? For instance, I didn't go on HRT until after I'd been through menopause. And it was some years later. I've only been on HRT probably for the past 12 months, actually. And it was because I was one of those women who believed the information about, it causing breast cancer and so on. So I did the suffering. I'm one of those women who did the suffering, ended up with the information. But for example, if you're 60 years old, if you're 70, if you're 80, and you haven't had a period for however long, should I stay on HRT for the rest of my life? Is there a point in time that I should be stopping HRT because it's no longer good for me? What should women be doing as they get older?
So again, it's always very individual. So there is no one size fits all. I think that's really important. And that's both in terms of the benefits, but also what your own choices are. Hormones work while you take them. We have the most evidence about, women who start them earlier. We've only got studies looking at women who've started them up to the age of 80. So there is some safety data on women starting hormones, even older synthetic hormones up to the age of 80. In terms of the long-term health benefits, we know with bone density that your bone density will start to fall when you come off your hormones. And, so whether you're treating symptoms or trying to prevent future disease, I think that comes into your decision making. Some women will flush for the rest of their lives if they don't take their hormones. Other women, the flushes were never an issue. So I think it depends on you, what you're trying to treat, what you're trying to prevent, and your own health belief structure. Hormones will do the job of multiple other medications. And I do have a small number of women who've really got into their 90s, but there's a small number who've not needed really any medications, but they've all got reduced bone density. So even if you were just looking at that, then the hormones would support their bone density. So for women who've started hormones within 10 years of their menopause and who are doing well on them and you want to continue on them, then there's no reason to stop. There's no evidence that you need to stop your hormones if you have a heart attack. There's some good data that shows that using estrogen after a heart attack is still safe. They've actually studied it to see if it improves outcomes. It doesn't seem to make it better, but it certainly doesn't make it worse. For women who get a hormone cancer, like a breast cancer, then they are, or breast cancer, whether it's hormone driven or not, they are usually recommended they are always recommended to stop their hormones at least while their treatment is completed. And then after treatment is completed, it should become an individual discussion as to whether they want to restart it for symptoms or disease prevention. So I have quite a few older women who've stayed on HRT, ignored probably me back in the day, telling them they should stop it because they've really hit that time. And they did fine, and it kept them well, living independently, traveling the world, doing the things that they wanted to do. So the current thinking would be there is no age that you need to stop, but it always would be individual. And that is based on several factors. In terms of starting it when you're older, it isn't always as effective when you've not had estrogen and progesterone for 20 years or longer. And the receptors can struggle to come back online because you can get, a bit of vaginal bleeding or sore breasts. That can be quite confronting if you've sort of really been away from that phase of your life for a long time. Testosterone seems to be better tolerated. It's more of a gentle hormone when it comes on board. So that can help women who are a bit further past menopause who don't want to do the estrogen progesterone thing. So, but it's really individual. I have quite a few women who have started hormones well past 60, into their 70s, and they just feel stronger and fitter and they can do what they want. But it's really so individual.
And it seems such a good indicator for longevity as well to stay on HRT. We know that estrogen is really great for that in terms of osteoporosis and so on as well, right? So if we're wanting to maintain our longevity, then would you say that HRT, it's good to stay on HRT to assist with that?
Yeah, I certainly would never come off mine. So that everything I've read, especially if you only look at the bone data, it builds bone as well as any of the other drugs, not in all women, but certainly in a reasonable number of women. And bone density is really connected to cardiovascular disease and dementia. So strong, loss of bone density increases your risk of those other things because the bone is another active endocrine organs with the chemicals that bone produces talk to the brain and talk to the heart. So when those chemicals, those mediators start to fall, you're going to get more stiffness in your arteries. You're going to get a bit of stiffness in the heart. You're going to get some loss of brain tissue as well. So your bone talks to your brain and your heart, and so maintaining bone density is so much more than just preventing fractures and maintaining mobility. It's actually also probably maintaining heart and brain health. And I think if we look at that, then really that gives us a lot of evidence, or certainly a very good reason to not be trying to stop women at any particular age if they don't want to.
Some powerful reasons there. Now, I must say, when I knew that we were going to be having a chat this week, I put it out on my socials that we were going to be having a chat, and I invited my community to hit me up with some questions to ask you. And overwhelmingly, what women are really concerned about was the weight gain and the change in body composition. What are your thoughts around that in terms of what's driving that and what actually works to reverse that?
So we know that women, if they don't change anything, will gain visceral fat as they go through menopause. And that again comes back to this loss of estrogen and probably progesterone and testosterone, again, not well studied, really driving inflammation and insulin resistance, and means you grow more fat cells, and the more fat cells you produce, the more inflammatory mediators they produce, and you get caught in this beautiful vicious cycle of inflammaging, which drives this central weight gain, which can manifest itself just as weight. But some people don't see the weight gain. It's actually gathering in their organs, and we don't see anything on the outside. So you can be toffee, which is thin on the outside and fat on the inside, and you'll only see that on a body comp scanner, which is quite confronting. So women can have a normal BMI and they have gathered quite a lot of fat around their liver. So we know that non-alcoholic fatty liver disease, or NAFLD, or it's now called MASH, increases across menopause transition as well. So that's that fat being deposited around the liver cells, and that then drives a lot of the other metabolic issues. So it's not that you're lazy, it's not that you're eating too much, you're not moving enough. The loss of estrogen, your batteries are draining and your metabolism slows, and you move into this kind of storing up the fat for the famine that's ahead, which unfortunately there isn't a famine ahead. It's really just going to drive chronic disease. So the earlier you start to lift weights, the better in life. And that's, as you're talking about your daughter in her 30s, like I'm lucky. I did, for whatever reason, I can't remember what it was. I started lifting in my late 30s, and I think that's put me in good stead. And so the more muscle you have, the more metabolically fit you are. You keep that insulin resistance down. So building muscle as early in life as you can, and then looking at nutrition, really trying to optimize protein and fiber. So feeding the gut to protect the liver. So stopping the sort of absorption of these kind of things that are bad for you. You can do things like if you want to be a bit fancier, continual glucose monitoring. So you're not getting huge spikes from foods, if you're already eating well, but that's only good if you have already really addressed the basics like eating real food. Sleep, laziest way to maintain your weight. And also for some women, you have to really check because we lose a bit of airway tone as we go into menopause. So a lot of women do start to snore, might get a bit of sleep apnea, and that poor quality of sleep, even if you are getting enough hours, again, will drive metabolic dysfunction. But if you're in a heteronormative relationship, usually your husband snores louder than you do, so you usually get missed. So we really underdiagnose that in women as well. So, looking at those things, but it's really, lift weights, eat protein as much as you can, take away 10 and aim for that, and plenty of fiber and get enough sleep.
I didn't know that one about the throat. That's a new one for me. And I must admit, I think I've been snoring a little bit more recently. What are your thoughts on mouth taping to encourage nasal breathing while you're sleeping rather than your mouth dropping open while you're sleeping, and it might be a result of that muscle tone?
No, I have to say I have done it, and I haven't ever looked at any trial data to see if it is evidence-based. I definitely, when I've done it, my sleep quality vastly improves, but that's anecdotal. And I don't know, actually, I'd have to see. Have you read, is there any good trial data to say that it works? I don't know.
I've been looking for trial data. I've only heard anecdotal, evidence as well. But certainly I have been doing mouth tapping as well. And I find that I do sleep better because I'm not waking myself up snoring for starters. So that's always a good thing. But equally, I've got a deviated septum as well, which I've got to get fixed. And so, having to try to breathe through my nose at night time, I find it very difficult. But I find the mouth taping helps to be able to force the oxygen through the nose rather than.
But there is some evidence that if you do breathing practice when you're awake, that your breathing when you're asleep does also change. So trying to do breath work where you do that kind of box breathing, there is some small studies that do show that your sleep breathing will change as well. But especially women who are hypermobile, who are bendy bodies, that's certainly, I always say that's about 80% of my patients for whatever reason. So especially if you are hypermobile, you're I think at increased risk of having that change in airway tone, just because that loss of estrogen then really compounds that. So you can be a bit floppy in the larynx and the pharynx in the back of the throat. So certainly if you used to do the splits when you were younger, you would probably have an increased risk of sleep apnea and things like that.
I've never done the splits. I can't even say the word because I've never done it. No, absolutely not. So we've been discussing sleep. That is one of the first things often that goes when people go through perimenopause and menopause. And it's so frustrating. I know that I suffered for years with bad sleep and I've been able to get on top of it now. But what do you think women can do to get on top of improving their sleep when they're going through that? And what is it with women waking up in the middle of the night at 1 a.m. or 2 a.m. or 3 a.m. to have to go for a pee? There are so many women that I hear that speak about this particular issue. What's going on there and what can we do to stop that from happening?
So different things. Our hormones fluctuate over a 24-hour cycle. There's maybe a bit of a cortisol peak, that in the middle of the night, that panic. But definitely and I think this is where all the hormones do talk to each other. So the certainly progesterone and estrogen can really improve sleep. So there's obviously either these, I think one, the fluctuating, but also the falling and the interaction of the falling hormones. Melatonin, there's some good evidence that one of your sleep hormones, melatonin, doesn't work in the absence of progesterone. And progesterone probably checks out before estrogen for most women. Even if you're having regular periods, your progesterone may already have plummeted. And so things like melatonin won't work so well. So it's a crosstalk between all the hormones, and sleep architecture is so complex that when any of those bits are out of whack, then either falling asleep can be difficult or waking at 2 to 3 in the morning thinking about the apocalypse will happen, often with anxiety, racing thoughts and palpitations. The waking up to go for a pee is probably a combination of the loss of hormones on your kidney system. So you don't tend to manage your fluid balance as effectively as a woman when you lose estrogen, because again, every single cell has estrogen receptors. So how we process fluid and how our kidneys sort of manage that will dramatically get affected by loss of estrogen. And then you've also got the loss of hormones in the vaginal tissue, which then impacts the bladder. So you've got a slightly irritated urethra, which is the tube that comes out from the bladder that's, now a bit unhappy because there's no estrogen around there. You've got kidneys that are struggling because they're getting sent all sorts of weird information about whether they should pee or not. And then you've maybe got a bit of change in breathing. That sort of sleep apnea then also can drive disrupted sleep, but also can affect your fluid balance. So it's sort of misinformation coming from multiple angles. In terms of what you can do, sleep hygiene, always critical. So all the things we do nowadays in terms of social media, working on our computer at all hours, drinking so many fancy coffees, trying to do 1,000 things in every 8 hours and do 3 different jobs. That all needs to go. You need to get up with the sun, try to go to bed when it goes down. Get your lights, your LEDs, your screen time all down a good hour before you go to bed, because you need to be able to wind down. Putting your body temperature up so it then falls is really useful. So having a warm bath or a shower or even just a warm drink, depending on whether the bladder is an issue, can all help that body temperature fall, and sort of mimics the natural sort of temperature rhythm that you would get in the real world if you weren't living in a house. And, if you are stressed and worried about things, doing a bit of journaling, getting sort of declutter your brain before you go to bed, like sort of, unpack the dishwasher. And then, doing some real active relaxation, which might be breath work or, 5 minutes of yoga, or just lie flat on the floor. I think grounding is really underused, and that you don't need to go and do anything fancy with a grounding mat or just lie on the floor, like put your feet up, get the blood back to your brain, like simple stuff. And then the use of hormones. I mean, that's one of the places where people find the hormones just change their lives, that they actually can sleep. And progesterone works on the GABA receptors, which is the same receptors that Valium or sleeping tablets work on, without the addictive potential. And for about 80% of women, it's a game changer. And then estrogen, I think, keeps you asleep. And sometimes you can add in melatonin into that mix as well, and a little bit of evidence for testosterone. So definitely sleep hygiene. Your good night's sleep starts the moment you get up, though. You can't suddenly try and sort out your sleep at 9 o'clock at night. It's been happening all through the day. Really looking at that 24-hour clock in every cell is really, really important.
Yeah, absolutely. Vaginal dryness, UTIs, painful sex, these are all other problems that women suffer with as a result of going through menopause. Talk to us about these issues and what we can do about addressing these particular concerns.
So this literally is the lowest hanging fruit in the medical world, and it's so badly done. So somewhere between 70 to 90% of women by the time they're 70 will have symptoms like these, which collectively are called the genitourinary syndrome of menopause. And less than 10% of women are given treatment in the form of vaginal hormones, for which there are no contraindications. So all women can have them, even women who are actively being treated for breast cancer. You do not. Estradiol. That's vaginal estrogen. So Ovestin or Vagifem or Intrarosa is vaginal DHEA. I don't think they should have a prescription. I think you should be able to buy them from the pharmacist. It's something I would love to see. That's certainly happened in the UK already. And they are, for the majority of women, very effective. So you just work, and again, it's working out what's right for you. Most women use, a preparation 2 or 3 times a week if it's Ovestin or Vagifem, or every night if it's the DHEA, and it will reduce vaginal dryness. It thickens the vaginal mucosa, but it doesn't just improve the vagina and the vulva. It works to improve bladder health. So you're reducing your risk. If you're somebody that gets urinary tract infections, you reduce that risk by 50%. And you reduce, for these older women, over 55, you reduce. So, it's a big range, 55 to 100. So for women who get recurrent UTIs over the age of 55, if they use vaginal hormones, if we reduce the risk of them going into hospital by, I think, I'm not going to remember the numbers exactly, it's by half again, but you reduce the risk of death by 70%. We don't have anything else that has really no contraindications that is effective for symptoms and will reduce your risk of dying from something as simple as a UTI. So this is something we really need to change. We need doctors to just ask women every time they're in, do you need, get over our issues about asking about vaginal dryness, but really thinking about this as a bladder health and, as one of the simplest ways to reduce a common cause of infection and disability. Like recurrent UTIs are no fun. Incontinence is not great crack either. yes, it's important to do pelvic floor physio and everything, but vaginal hormones really should just be sent a tube of it on your birthday every year. Probably do more than all the other things they do for us. And there's other things like vaginal moisture. So you certainly need the vaginal moisturizers, making sure you use a lubricant are really important as well. So, don't just have a glass of wine and lie back and think of whatever, really look after your vagina, but they're not just for sex. That's the way that you protect. It's protecting your bladder health as well. So really regarding it as an important organ that needs looked after, because again, that's the one area that you don't manage to compensate for loss of estrogen, like the brain rewires. You could argue the heart probably doesn't really cope, but the vagina doesn't. So unless you put those hormones back in, for the majority of women, not all women, but the majority of women, it will dry, your labia will shrink, and you'll start to get urinary symptoms.
Yeah, great advice. All right, libido and orgasm changes. Again, that can impact women as well. Talk to us about that and what we can do around managing that or improving that as we get older.
So that's an easy, fast one. So libido, very complex for women. We don't just have an off-on switch. Libido is very different for everybody. Simple things are obviously women tend to live in their head, so they don't live in their body. We're so busy juggling the mental load of life that we kind of can forget about the neck down. So, again, doing a lot of things that really do allow you to come back into your body. So a lot of that is relaxation, meditation, just getting comfortable with yourself again. And whether that's sexually or not, it's, it doesn't matter. It's getting back into the body. So things like yoga and Pilates, all of those things can really help, but really trying to relax, allow your brain to clear. Women tend to need lot longer than 2 minutes foreplay. And that really is more than just the sexual foreplay. It's really getting yourself in the mood, can take hours, so you need to have space in your life for that. And so with your partner, connecting, there's some brilliant books out there in terms of getting used to touch and everything again. So just sort of getting used to, the feeling of pleasure in your body. And it doesn't necessarily have to be going straight to sex. So maybe if you have really got out of the habit or you're struggling, then going back to basics, but also making, looking at your emotional connection, spending time together, scheduling time that you do have time where you are in the moment together. Because I think that gets lost. It's just another thing to do at the end of the day. And for men, that is easier. For women, that's often impossible. In terms of medication, and so things that can really contribute to that, if you've been put on an antidepressant, that can really reduce libido, it can reduce sexual arousal. Arousal does decrease with menopause because of these changes in the vulva and vagina and clitoris. So really important to look at vaginal hormones to maintain the health of that area. Testosterone is licensed for low libido in postmenopausal women. It's effective for some, but it's definitely not a magic bullet. It really usually, for most women, needs to be in the context of looking at connection and time and general health and stress levels. Testosterone is the only drug that we have in Australia for low libido. There are pills like Addy in the States, which we haven't been able to get approved here, which really can be very effective for low desire. So it'd be exciting if we could have more than one treatment, but if we get one, that would be great. And so I think really you do need to probably look at it a bit of in the biopsychosocial, but not forgetting the biological part, which we have traditionally forgot for women. We've really focused on counselling, but actually remembering testosterone, estrogen, progesterone in the brain, really important for libido, and in the vulva and vagina to make sure that skin's healthy. And then the other stuff is more complicated and might require, some sexual, sex therapy, but certainly even getting yourself a decent book, making sure you've got a vibrator, getting used to playing by yourself without the pressure of performance. And we've got some fab vibrators made by Australian women like Elixir Play. And, so they're great. So yeah, I sent a lot of women off to buy a vibrator. Had women in their 80s getting their first vibrator. So you're never too old to start, that. Which I just think is great.
I love that. That's awesome. I think it's interesting what you mentioned about testosterone though, and what's available for men in terms of addressing their libido here in Australia. I think there's quite a fair bit available for men, but not so much for women by the sounds of things. That's a bit discriminate there.
Oh yeah, no, I mean, the whole of health is very discriminatory. So men there's 9 testosterone products for men and they're all available on the PBS. Although to be fair, men really struggle to get testosterone prescribed for them as well. To be honest, it's not something that's done well in men either. Men can easily get drugs like Viagra, which works to dilate the blood vessels. So it's really working on blood flow rather than on the brain and desire. And women, low libido tends to be more complex than just most women don't have arousal isn't their primary problem. You can actually make Viagra into a cream and get a compounded pharmacist to do that. So if arousal is part of the problem, then actually you can use a Viagra cream in women and that can help. But yeah, men do have more products, but still I think we could do better for our men folk as well in this area. It has been a neglected area, and it's been really stigmatized even for men that, when they've tried to get things onto the PBS, it's been looked at as a recreational and not necessary thing. And I think that is unfair. I think for both men and women, being able to have a healthy sex life should be regarded as part of health, not as an add-on, maybe take it or lose it, take it or leave it. So definitely men and women, it needs to be done better.
Yeah, completely agree. Another consistent question that came up on socials was brain fog and those mood swings. Brain fog in particular, what's your recommendation in addressing brain fog and what should women be doing?
So brain fog has lots of causes. Our estrogen, progesterone, testosterone are all neurotransmitters. So they all directly impact how you think, how you feel, how you learn, how you behave. So when they are fluctuating or checking out, then your cognitive function will be affected in most women at some level. All three hormones can improve cognitive function. We've got the best data for estrogen and a small bit for testosterone. But you have to rule out other causes of cognitive changes, which can include sleep apnea. So that poor sleep quality is really important. Then also some people just are running at high levels of inflammation. So we've got some people that do have quite heightened immune systems. And if your immune system in your brain is running high, that means you will be running with these high levels of inflammatory chemicals in the brain, which can contribute to brain fog. So this area that I'm interested in terms of hypermobility and mast cell activation, brain fog would be a common symptom for those people, male or female, right across the life cycle. So that kind of chronic fatigue, thinking through treacle is something that some people will experience, not associated with perimenopause. So you can do things with trying to settle the immune system down to improve that there. Some other people, if they've got hypermobility, or they can have congestion of the veins in their pelvis. And there's a theory that stops effective circulation of the glymph from your brain, the glymphatic fluid. So there can be some unusual things that can contribute to brain health. But for a lot of people, adding the hormones back in is actually all you need to do. And addressing sleep quality. Those would be the two big things. And then there's supplements, to support brain health, in terms of NMN, NAD, and some of the things that will reduce inflammation. You're kind of getting a diminishing return on investment. Exercise, great for brain function. Sleep, great for brain function. But yeah, a lot of people do say their brains come back online after they add testosterone into the mix.
Yeah, completely agree. Look, I could talk to you for hours, but I know you don't have time to talk to me for hours. So we're going to leave it there by one more question that I ask all my guests. What does it mean to you to live well longer?
Oh, I think I just want to live a healthy life. It's not so much about length. I want to be strong and independent and able to do the things that I want to do for the time that I'm here. And hopefully that will include climbing mountains, surfing into my 70s, and being able to be a fit grandmother if I ever get any grandchildren, because I've had my third child quite late. So I have to really look after my health if I want to have any chance of being around for her kids. So so being able to do the things that I want to do, living strong and independently. And, really, I want to be one of those badass older ladies that wears crazy clothes and still goes to the gym at 85, which was kind of what my granny was like.
Yeah, I'm with you on that one. I think living audaciously the older we get, I think is the way to go.
Definitely.
Dr. Ceri Cashell, thanks so much for your time today. You've been an absolute wonder in terms of all of the information that you've shared, and I know that a lot of my listeners will get a lot of benefit in all of the information that you've shared today. So thank you so much for your time. We're truly grateful.
Thank you so much for having me, Azra. It's been a pleasure.
Well, that's a wrap for today's podcast. Thank you for tuning in. And if you'd like to learn more about biohacking, go ahead and sign up on my website at www.biohack-her.com to get a free copy of my 5 top biohacks to get you kick-started. While you're there, you can also check out my blog page for more tips on biohacking. If you'd like to subscribe to this podcast, you can do so on Apple, Spotify, and Google Play. Let us know if there's anyone you'd like us to talk to in particular, and we'll endeavour to get them on the podcast. Until next time, remember to live well longer.